I felt the same way. I watch television some nights and I see all these people smiling and playing golf, and it says, check for tuberculosis, cancer, diabetes. And I said, oh my God. And then I found out what the issues are. These antibodies are targeted to interact with the immune system. That's what causes the problem. The antibody is the thing that does it. The antibodies for CGRP are clean. All parts of the antibody that would interact with immune cells or with anything else have been wiped out by the magic of genetic engineering. So to remember, it's not the antibody that causes trouble, it's what it does for a living that causes trouble.
So to summarize that, the previous antibodies commonly used in neurology are immunomodulating.
Correct.
While the antibodies which target CGRP and its receptor do not appear to have any immune modulation characteristics.
They have none.
And we assume, therefore, that we will not see opportunistic infection or neoplasm further down the pike. That's the assumption that we make with these. And it's very exciting because it's the prospect of using targeted antibody therapy without the consequence of the immune consequences,
That's
the potential
exactly
immune consequences.
correct. Remember, an antibody is a tool, and the tool can be modified depending on what you want to do with it. Exactly.
So it's just important to consider, what does CGRP do in the body, taking all of this into account. You've explained that it's not part of the immune reaction, but it does have an inflammatory effect. It's involved with neurogenic inflammation and vasodilation.
Okay. The best idea of what CGRP does in the body is responsible for peristalsis by activating muscles in the gut. There's a great big deal of controversy about immune reactions, neuroinflammation, and plasma protein extravasation. The older I get, the more I read, the more confused I get. To the best of my knowledge, CGRP does not produce plasma protein extravasation directly. It can activate mast cells and other neuromodulators and perhaps produce it. And it's an argument as to how much involved is neuroinflammation in the biology of migraine. And that's the next topic that we need to talk about. It's still very vague. And I think I spent the last 10 weeks reading about it, and I'm more confused than ever. I just think nobody knows the answer to that question.
But you would agree that CGRP is the most potent endogenous vasodilator.
Absolutely, 100%. And the miracle is, when it's blocked, it makes no difference. That's the amazing thing.
That's the amazing
Which means that there has to be alternate pathways to compensate. And think about it. Body is known for its redundancy. So basically, and the other point would be is, if it was the only thing that mattered, why wouldn't the antibodies be 100% effective in everybody? We have to have parallel pathways where one picks up where the other lets off. And there wasn't some recent data today by Lars Edmondson showing, or yesterday, clearly showing that if you constrict or relax blood vessels, giving CGRP antibodies makes no difference, except when you're trying to have them dilate with CGRP itself. That was pretty nice to see that data. I think we have a lot to learn, really a lot to learn.
Yes, we definitely still have a lot to learn, especially with respect to people who have vascular disease and other risk factors for ischemia. Because while we have multiple mechanisms for the regulation and autoregulation of vascular tone, particularly in the brain, we know that even in the absence of arterial narrowing or atherosclerosis, some people are more prone to vasospasm than others. And we don't know what those mechanisms are. And if they happen to be non-CGRP, and you take out some of those corollary mechanisms for vasodilation, you might be putting somebody like that at risk. But we don't know, because we haven't really
seen
looked.
it yet, but we need to keep our eyes and ears open.
That's exactly what I was going to say. At this meeting in the AAN in May of 2019, a variety of randomized controlled trials and open label extensions have all been plumbed, looking at 4 monoclonal antibodies to see if there's any signal for a vascular safety issue. And so far, there's been zero signal. Now, it's a new class of medicines, and vigilance is important. It is reassuring. And the assumption is, if this does not turn out to have a vascular risk, which so far it looks really good, and I wish this table was wood so I could knock on it, it's because the system is so redundant.